Well, you are most welcome to this video, and I'm delighted to have with us today Dr. David Grimes. Dr. Grimes, welcome.
Thank you, John. Very nice of you to invite me.
Now, I've been looking forward to this because Dr. Grimes has been a physician for a long, long time, medical researcher, medical author, and he's been through the whole development of vitamin D and the understanding of vitamin D and the importance of vitamin D for health and for immunity. So we're going to get some really good insights if you want to stick around for this video. And we've got some PowerPoint slides here, David, haven't we, to look at. So should we start off with the first slide, and you can tell us what it's about?
Well, basically,
We're starting with this one.
no.
Oh, I want to go back.
No.
Okay, right.
Okay.
Yeah, go for it.
You can put me on as well if you like.
No, you're on. Oh, okay, right.
Yeah.
Yeah.
Basically, I've had an interest in vitamin D for a long time. I'm not what might be called a trained expert in vitamin D, but I've acquired a lot of knowledge and experience through my work as a physician, working mainly in East Lancashire in Blackburn. And what concerned me initially was that there were groups of people who were very susceptible to illness and a short life. And these were in particular the poor people, people in the northwest of England compared to the southeast, and also the South Asian ethnic immigrants into Blackburn, of which there are a large number. And I thought, well, what's the common feature? And that's what we must look at, common features. This is what's called Occam's razor. What do these people have in common? The South Asian ethnic people, the poor people, the obese people, and people living in the inner cities and in the northwest of England in particular. And I came to the conclusion the only thing that we could explain would be the climate, sun exposure, and vitamin D. And I did quite a lot of work on that. Now, in 1968-69, I was the resident medical officer at the Manchester Royal Infirmary. And at Christmas time, we saw the onset of the pandemic of Hong Kong flu. And it was pandemonium in the hospital. There was no planning for it. It just happened. And we had to deal with it when it came along. We didn't have any intensive care units in those days. There was no public health initiative. There was no government involvement. But we got on with it and we dealt with it. And after about 3 months, the pandemic went away, and that was the end of it. A little bit later in the year, but nothing very much. Now, when it came to the COVID-19 pandemic, which we were anticipating at the beginning of 2020, I thought, we now know a lot more than we did in 1969. We know now how to improve immunity. We know now about vitamin D and its importance in the development of immunity, and we should be able to do better than in 1968-69. And in 68-69, there were about 50,000 deaths. So I confidently thought, right, we're going to do far better than that with the COVID-19. I fully expected medical science, government, public health to mobilise the knowledge of vitamin D, but it didn't happen.
This is things that you've learnt and other colleagues have learnt over the last 40 years.
Absolutely.
That knowledge was sitting there.
Yeah, yeah. That knowledge might as well never have happened as far as the COVID-19 epidemic developed without the involvement of vitamin D. Was it ignorance? Well, the people shouldn't have been ignorant. I was an ordinary physician in an ordinary hospital in an ordinary town. Well, surely people in the academic centres should have known about this. See, it was predictable that the obese, the South Asian ethnic people, Black African ethnic people, the poor people and the elderly, it was inevitable that they would succumb to COVID-19 in a big way, and they did. And it was ignored. It was preventable.
And you anticipated this?
Yeah, I anticipated it. And so did others as well. And we did our best to try and bring the importance of vitamin D to the attention of public health and government. But they didn't want to know, quite frankly. Everything was rejected. And so we finished up with, in 2020, there were about 80,000 deaths from COVID-19 in 2020. Well, which was more than we had with Hong Kong flu. That wasn't anticipated. We can look at these. If you look at the next slide.
Please.
You say you want me to... Yeah. If you look at this, this shows, for example, an example of vitamin D produced. It says here, without sunscreen and with sunscreen. And we can see without sunscreen, we had a lot of vitamin D produced after exposure to vitamin D. With sunscreen, vitamin D synthesis is basically blocked.
So it goes right up here when we've got the vitamin without sunscreen, the natural exposure to the sun.
Yeah. Now, without sunscreen, you can say that is a white skin. But the body has produced its own sunscreen, melanin in the skin, and so dark skins have the natural sunscreen. So dark skins produce less vitamin D with a given exposure to sunlight. And now we can come on. Just to emphasise what happens, if you just move to the next slide.
Yeah. What fascinates me here is that the whole reason for us turning white when we evolved coming out of Africa would be to make more vitamin D.
Yeah.
Otherwise, we'd still have dark skins.
We would, absolutely, wouldn't have survived.
Yeah, so just go. Probably.
Okay, you're going to use it. Now, here we just see...
Yeah, that's the next one, isn't it? Yeah.
This is what happens, just to refresh memories.
Yeah.
The body creates a substance called 7-dehydrocholesterol, 7-DHC. Yeah. This is an oil, and it was first produced 1.5 billion years ago by plankton. And that's how fish get vitamin D. They can't produce vitamin D. They're in the ocean, or they're covered with scales. Fish cannot produce vitamin D, but they can eat it when they eat plankton. And that's why fish are rich in vitamin D. Now, here's the vitamin D produced by the action of the sun on this single bond within the molecule of 7-DHC. And when that happens, vitamin D is formed. I won't go into further details about that for now. But what happens next slide.
So this whole thing's in the skin.
That's produced in the skin.
The sun kind of cleaves this bit off and we get this activated bit left. Yeah.
It changes shape.
Yeah.
Once that is broken, the shape changes and it becomes known as vitamin D.
Yeah.
Now, this is what happens in the young people. Now, young people, we get this big increase in vitamin D and exposure to the sun, ultraviolet light. Now, young people have nice oily skin, but as we get older, our skin becomes dry.
I've noticed.
It does. Our skin becomes dry because the elderly skin does not produce 7-DHC. One of the main features of aging is the change in the skin. And so elderly people, we can see here, they produce very, very little vitamin D.
Yeah, very low.
It makes very little difference compared to young people.
Huge.
Elderly people are inevitably deficient in vitamin D unless they take a supplement or unless they eat oily fish twice a day. You can put elderly people in care homes out in the sun for as long as you like, but they will not produce vitamin D. So the elderly people, therefore, like the people with melanin, with dark skins, are inevitably vitamin D deficient everywhere. Now,
I mean, I did notice this. I had a lot of time in the sun this summer, but my vitamin D levels didn't go up that much.
No.
Whereas 20 years ago, they would have gone up quite a bit more,
they would
presumably.
indeed. Yeah.
And not many people, I've only learnt this from you.
Yeah.
I knew that old people produce less vitamin D, but I didn't realise how much less is produced. So that's a really valuable lesson for
this slide is taken from a BMJ, British Medical Journal paper, 1974.
Wow.
This is not new knowledge. 1974, believe it or not.
Yeah.
But it's not known.
Yeah.
You can find it. I've got references to it. I've got a copy of the paper, PDF of the paper.
1974.
But nevertheless,
wow.
yeah, indeed. Yeah.
Amazing. Yep.
The obese people. I mentioned we've got people with dark skins, people who are elderly, and the other group who are going to succumb were the obese. Now, this is from quite an old paper, but I've reproduced the image here.
Mm-hmm.
Look at controls.
Yeah.
The blue is before ultraviolet exposure.
Wow.
And we can see these people were all very, very deficient in vitamin D.
Yeah.
Only 5 nanomoles per litre. That is very low indeed.
Yeah.
And the control group were given, these are people who are non-obese, were given an ultraviolet exposure, and it went up in a big way.
It's huge, isn't it?
Yeah. There's the benefits of ultraviolet light on vitamin D production. But if you look at the obese people, they produced only half the amount of vitamin D. Well, I say they produced only the half, but the blood level went up only to the half extent of the non-obese. Because what seems to happen in the obese is the oil, vitamin D, becomes trapped in the fat cells of the body. The vitamin D goes into those fat cells and it stays there. And so it's not available for metabolic use and for the benefits of immunity. And that's, I'm afraid, the way it is with the obese. So it's predictable that the obese would become very sick with COVID-19.
So it's a fat-soluble vitamin, isn't it?
Yeah. Yeah,
it'll just go into that fatty tissue. It'll just sit there. And it's a bit like having your car in the garage. If it's parked in the garage, you can't be driving it around the streets.
True enough. That's a good analogy.
Yeah.
Absolutely. Yeah, indeed. Yeah. Absolutely.
But huge difference on that graph. So, again, completely predictable that the elderly and the obese would have vitamin D deficiency.
Yeah, that's right. That's right.
Yeah.
So, this is one picture of the of healthcare workers who died from COVID-19.
Yeah.
We can see quite clearly that the people with dark skins, Black African and South Asian immigrant ethnicity, were overrepresented.
Yeah.
And it was terrible to see it. Just next slide.
Yeah. These are people that died.
These are people who died. Not all of them. This is a sample, which I came across.
Yeah, and there are many, many more that aren't represented in this graphic. Yeah.
One thing to look at is this information comes from the British Medical Journal. Yeah. Now, I tend to read journals and magazines from the back when I'm sitting down, flick through. Yeah. And on the back page of the British Medical Journal, virtually every week, are about 6 obituaries for doctors who've died. Yeah. And during 2020, these are the ones who died from COVID-19, who had obituaries in the BMJ.
So this is data you've taken from the BMJ.
Yeah, I have indeed.
And I think it's interesting that there's a long history in this country of getting medical information from doctors.
Yes.
If we think about going back to the lung cancer and smoking, with Richard Doll and Bradford Hill, that was the British doctor study. Yeah. That actually revealed that data at first.
Absolutely. That was a very important study.
Yeah. As indeed is this.
Yeah, yeah. Now, the situation here is that we can see the age range, the age at death, and of the white, ethnic white doctors who died. The ages were between 83 and 107, or something like that, I think it was. Yeah. The average age at death, let me just look, the average age at death was 87.9 years.
In white doctors.
In the white ethnic doctors.
Yeah.
If you look at the Black African and South Asian immigrant doctors, the age range is entirely different. The age range is between 46 and 72. Wow. And the average age at death was 62. 62, 25 years younger than the white doctors. Now, this has been published in the British Medical Journal every week through 2020. I don't think I'm the only one who reads it from the back or looks at it or looks at the ages of death. But nevertheless, this is the information that's available. And it's terrible to see that. Why are people not taking notice of that? Saying, why is it? Now, it was generally thought that we had 3 independent inquiries into why ethnic minority people were dying from COVID-19. Yeah. And they all came up with the same conclusion. It was because they were poor. Socioeconomic deprivation and racism. Well, hang on a minute.
Well, medical consultants aren't that rich, but they do get paid somewhat.
These people are all being paid about the same amount of money.
Yeah.
Except the white-skinned people here were all retired, and the immigrant doctors, being younger, were generally speaking still working.
But these are people on relatively high salaries, living in middle-class areas, having a reasonably good lifestyle.
Yeah, absolutely. That's right.
There's
something biological about this, not sociological.
We always need to look for the biological causes first. This is what really annoys me about this. It's the same in psychiatry. You get people who behave abnormally, eliminate the medical possibilities for that first, and then think about the psychological. Go for the obvious biological possibilities first.
Indeed.
Yeah.
Move on. This looks at the blood levels of vitamin D. Now, this looks complicated, but the dark area is a series of vertical black lines, columns.
This is a histogram area.
That's right. Yeah. And each one is the blood level of vitamin D in individual patients. And there are 818 in this ethnic white group. And we can see here the middle of the range, the median, is the vertical line, orange line. And that marks off at 30, it goes up to 30 nanograms per mil, which is about the bottom of the ideal range. But it actually crosses the dark area at 18, but down a bit.
Oh, here, sorry.
Down. So 50% of this white ethnic group had a blood level of vitamin D less than 18, which is seriously deficient.
So all these people here,
the
blood level's less than 18. Yeah.
Now, how many had a blood level greater than 40 nanograms per mil? Very few.
Just these ones up here.
It shows the extent of vitamin D deficiency in the population of the country, of which Blackburn is just an example.
So your medical opinion as a lifelong physician is that 40 nanograms per mil is a good level of vitamin D?
Yes.
That's incredible. You're saying that nearly 90% of the population are vitamin D deficient.
Yeah, exactly.
Yeah.
Absolutely true. It's been demonstrated in many other countries as well.
Yeah.
But this was work that I did as part of my research when I was working as a physician.
Yeah. We should have mentioned that you did one of the first advanced research degrees in vitamin D and the importance of vitamin D.
This was part of my MD research, yes.
Yeah.
Yes, it was.
And an MD in England is the same as a PhD. It's a PhD for doctors, really,
Exactly,
American medical education is excellent, but all doctors in America are MDs.
That's right.
Whereas very few doctors in this country are MDs. It's an advanced research degree.
That's right. It is.
So that's just incredible. So
now the next one, remember that. Yeah. Now let's look at the South Asian ethnic people.
Yeah.
Wow. Now we've got 1,500 here. Yeah. Again, each vertical line is one person. Yeah. And we can see the middle of the range here in orange, and it shows in the yellow line
9
that it is 9. Yeah. In the white...
Just to remind ourselves again of the white.
The white was 18. Yeah. And the South Asian ethnic group, 9. And we can see here how few
are replete. 40. Yeah, very, very few.
I remember one in particular, a man from Bangladesh, who I thought, I bet this man's vitamin D deficient. He had a very good level. He had a level of 50. And I said to him, how come? I thought, why is this? I said, do you eat a lot of fish? He says, oh, yeah. He said, I eat fish every day. So what sort of fish do you eat? He says, Bangladesh fish. I said, where do you get Bangladesh fish? He says, I get it in Tesco. And so I go along to Tesco in Accrington, and there it is, big packages of white Bangladesh fish, rich in vitamin D, obviously.
Okay, interesting.
It is indeed.
You know, I talked to an Indian researcher a few years ago, a couple of years back, and he was doing work on the 1918-1919 pandemic.
Yes.
And he found that the death rates in Kerala
Yeah.
were much lower than the inland parts of India because and his idea was they ate a lot of fish
Yes.
in Kerala, whereas the highland areas, less vitamin D from fish.
That's interesting, actually.
Yeah.
Because, Bangladesh is a fish-eating population, as opposed to Pakistan, which is inland and is not.
Yeah. Well, striking difference between.
Yes, indeed.
So you must have been the first person to collect this kind of data, David.
Well, on this in these numbers, probably yes.
Yeah.
Although it was known that.
But this is quantitative evidence: the white population, the Asian population.
It was known from work in the 1960s that the South Asian people in Rochdale were very deficient in vitamin D, high incidence of rickets, for example.
When was that known?
That was, I think that was in the 1960s, early 70s.
1960s,
yeah. Yeah.
And this is a very poignant slide, isn't it?
Yeah. This is the cemetery, the main cemetery in Bradford.
Yeah.
And this is the Muslim section of it.
Yeah.
And this is heartbreaking. Just these were people dying. They needn't have died.
Unnecessarily.
They died. Yes, they had COVID-19. They died from COVID-19. Why did they die from COVID-19? Because they were seriously vitamin D deficient.
Yeah.
This could have been stopped.
Yeah. And for people watching in the States, Bradford is an area with a high South Asian,
it's very much so.
Muslim population.
Yeah. The largest Muslim population in the United Kingdom is there.
Yeah.
And this is just heartbreaking to see this.
Yeah.
This was a photograph, I didn't take it myself. It's from one of the newspapers. But it's the message is there.
Brings it home.
Why did it happen?
Yeah.
Why was it allowed to happen? Now, what did happen is that I told a friend of mine, Muslim friend of mine, runs a local garage, and where I used to get my car filled up with petrol. And I was telling him all about this. He said, "What you must do," he said, "we've got to get this message across the population." Yep. And so what he did, he recorded me talking about it. Yep. This was just on his mobile phone in the garage. Me talking about it for the local Muslim population. And it went viral. I had people from all over the country phoning me up, people with South Asian ethnicity, saying, "I've seen you on a YouTube telling us all to take vitamin D." And that's what happened. It did a great deal of good.
I mean, we can't quantify it, but that is bound to have saved hundreds or thousands of lives.
I think it probably would have done. The high deaths from COVID-19 in the South Asian population, it ceased to be a story after the middle of 2020.
Well, it's all caused by socio-economic deprivation. We know what's causing it. We can write that one off, can't we?
That's right.
Yeah.
Yeah.
Appalling. Jumping to conclusions.
Yeah.
I mean, Austin Bradford Hill went to all the trouble of writing his criteria.
Yes, indeed.
And now they're just completely ignored.
Yeah, absolutely.
We have an established scientific method of investigation.
Yeah.
It worked for smoking, it worked for heart disease, it worked for asbestosis and mesothelioma.
Yeah.
And we just chuck it out the window.
Yeah, that's right. Yeah.
Yeah.
Very much so. It's tragic. This is just looking at blood vitamin D levels again.
Yeah.
And this time it's in Israel.
Yeah.
And the population of Israel, or the nation of Israel, gets far more sun than the population of Blackburn and Accrington.
Just a bit.
But we can see that half the population here had a blood level less than 20 nanomoles per mil.
So there's a very low levels here,
Sorry, less than 20 nanograms per mil, or less than 50 nanomoles per litre.
Yeah.
We do have these two units in circulation.
Now, this is a bit confusing sometimes. So typically in the States, we measure this in nanograms per mil.
Yeah.
Typically in the UK, because we've on System International.
Yeah.
We have it in nanomoles per litre.
We do indeed.
But the conversion is 2.5.
It is, yeah.
So
yeah.
if you have 20 nanograms per mil, you multiply 20 by 2.5, which gives you 50 nanomoles per litre.
Yeah. When I was doing my research earlier on, in this country, we were still using the nanograms per mil, but in recent years it's changed to nanomoles per litre to conform with the rest of Europe.
Yeah.
But,
and
most of the world.
It is interchangeable with other units. So it does make sense.
Well, the message here is that 50% were seriously deficient
in sunny Israel.
In Israel, and only 15% had a level greater than 40.
Yeah,
which is, as we'll see, is the safe level.
Mm-hmm.
So this is just showing again the extent of vitamin D deficiency.
Yeah.
Now let's move on. Now this is a slide showing in Israel again, which the people who were critically ill, and this is from Galilee, the hospitals in Galilee, and they had access to records of the vitamin D levels taken a year or more before the COVID pandemic arrived.
Yeah.
And then they looked at the people who are critically ill, that means on intensive care with COVID-19, and they were able to look through the records and find out what their blood levels of vitamin D were before the pandemic occurred. And there they are. And we can see that no one on the critical care unit had a blood level of vitamin D above 75 nanomoles, 30 nanograms. None of them. 90% were seriously deficient in vitamin D. 5% had low levels of vitamin D.
So no one at all here with these high levels.
That's right.
No one. And even 30 to 40, no one.
Yeah.
Huge amounts with the low levels of vitamin D.
Yeah. So you have to ask yourself, if you're faced with a pandemic of COVID-19, what would you like your blood level of vitamin D to be? Would like it to be less than 20.
Let me think.
Which column would you prefer to be in? You know,
I think I'd prefer to be in this column. Out for a nice walk in the Galilean hills rather than stuck in an intensive care unit somewhere.
Absolutely, yeah. And this
powerful slide.
It sums it all up here. That in the face of a pandemic of COVID-19, the public health measure is to make sure that everybody had a blood level of about 40 nanograms per mil, 100 nanomoles per litre. Dead easy. Easiest thing in the world to achieve that, public health. And what we could have achieved by doing so.
But it'd be very expensive, presumably.
Vitamin D's cost virtually nothing. And the blood test...
Is it cheaper than $25 vaccines?
Oh, well,
I'm being naughty.
It's virtually free, isn't it, vitamin D?
Yeah.
A year's supply for £10 or something like that.
I'm sure if we ordered it in bulk from Indian pharmaceutical manufacturers, we could get the price down a bit further even.
We're often told that it's too expensive to do the blood tests. Well, you can see from my research, I did 2,500 blood tests. It's only expensive if you buy it from somebody else.
Yeah.
They're going to charge you and they're going to rip you off. But if you do it yourself, it means buying the kit, a one-off purchase of the kit, and do your own blood levels of vitamin D, as we did in Blackburn, then it's cheap. Not a problem.
I mean, you've just described, we need to work out a way to that people, because people will be commenting, say, well, how the heck do I get this kit?
Yeah.
Is there some way we can do this? Or
yeah, it's very simple. You can buy it on the internet.
Right, okay. Right. Yeah. I mean, ideally get your doctor to do it if you can.
Well, it'd have to be done in a standardised laboratory, which is what we did. Yeah. But it'd have to be done in a proper laboratory for quality control, etc. But it can be done at a reasonable cost.
Yep. And if you're preventing 2 minutes intensive care time,
absolutely.
I think you've paid that cost back 100 times.
You have indeed, yes.
They're very expensive places to keep people in.
Yeah, very much. Yeah, indeed.
Yeah.
Now, one thing I want to demonstrate on this slide, it's a bit blurred, I'm afraid to say. But the skin produces 70 hydrocholesterol.
So this is the oily stuff that I'm starting to lack now I'm getting older.
That's right. The skin produces if you're young enough.
Yeah.
And the sun converts it into cholecalciferol, vitamin D, also known as calcifediol or calcidiol.
Yeah.
And the liver converts that. I'm sorry, it gets absorbed, and then the liver converts it very slowly into the blood circulating 25-OHD.
This is the calcifediol, is it?
That's the one. Yeah, indeed. And that circulates in the blood, and when it's required, it's taken up into the target cells, which are the cells of immunity in the main. Well, there are a lot of other cells as well, but we're talking about immunity cells. And that is very, very rapid. And that converts into the 125, which is the active ingredient.
So this conversion here converts it. And this is the calcitrol, this one, isn't it?
Yes.
Yeah. So that's very rapid.
Yeah.
So this is the when we do a blood test for vitamin D.
Yeah.
This is the one we're looking at
the
here.
25, the calcidiol, calcifediol. I want to emphasise the difference between the slow and the rapid.
Please.
So let's just move on to the next slide.
Yeah. So you're going to tell us what you mean by slow?
Yeah, I am indeed.
Yeah, good. That's what I want to know.
There we are.
Yeah.
This is what's called slow. So people are given a dose of vitamin D by mouth at the bottom.
Yeah.
And then the measurements are in different dose regimes, different doses. And every day, the blood vitamin D level as the 25-OHD calcifediol is measured. And we can see that it takes 21 days before we get it over 40.
So this, all in this time, the liver is starting to do this conversion.
It's doing it slowly.
Yeah.
Because there's no rush. It's like canal transport.
Yeah.
You know, as opposed to an aircraft. Like canal transport, it's slow and leisurely, steady state.
Yeah.
And it can take, it takes a long time, several days. Now, if you give somebody who's critically ill vitamin D, it's not going to do anything for a couple of weeks. And in those couple of weeks, the person will be dead. But there's an alternative. That is the slow process demonstrated. Now, let's look at the rapid process.
And this was done in so many clinical trials. You take people who are on death's door, give them huge amounts of vitamin D. Oh, we've proved vitamin D doesn't do anything.
Yeah, that was done in 2 trials in Brazil in particular.
And nothing's going to help people at that stage, apart from possibly steroids.
Well, even that's not, that isn't too dramatic.
Yeah.
But anyway, the difference now is the rapid process.
So this is the slow process.
That's the slow process of the part activation of vitamin D by the liver.
I mean, if you want your vitamin D to be up here, that means I need to anticipate my requirements, doesn't it? Now, am I going to be exposed to an illness in 3 or 4 weeks' time? Well, I don't know. But wouldn't it be good to have my vitamin D levels optimised?
Yeah, in advance.
Because it's pretty likely I'm going to be exposed to some bug in a few weeks' time.
Like the people in Israel, the ones who'd got good levels of vitamin D, above 40, they didn't die or become critically ill.
Yeah. But that was based on vitamin D they'd taken or been exposed to sunshine in the weeks before.
Yeah, a year before.
A year before, right. Wow.
Wow. Now then, we come on to the critical one of the 25-OHD, also known as calcidiol or it was calcidiol, now it's calcifediol. It's been changed a bit. And now we can see this is given by mouth. So it doesn't have to go through the liver.
This is the activated form that the liver would normally be produced. And we're taking a shortcut. We're actually giving this one.
Yeah, we are.
As a tablet.
We're bypassing the liver.
We're bypassing the liver. Yeah.
So we're giving what the liver does produce.
Yeah.
And we can see how quickly does it go up? Is it 2 weeks? 3 weeks? No.
Wow. It's 2 hours.
Yeah, 2 hours.
Wow.
Not 2 weeks, 2 hours.
Yeah.
And that's the difference. So if people are critically ill, there's nobody taking vitamin D in its raw form. We've got to take it in its part activated form, 25-OHD, calcifediol. And the speed of action is dramatic. And
I understand that. I'm not even a physician. That's incredible.
It is. Yeah. It is. And this is known, and this has been published, and this was known before the pandemic.
Yeah.
So let's see this in practice.
Wow, that is seriously fast.
Now we can see this is a bit out of sequence, but it doesn't matter. This is vitamin D on the need for ICU support with COVID-19 pneumonia.
Yep.
Red is bad, and yellow is good.
These are patients in intensive
Red means
care.
you're on intensive care.
Not good.
That's right. That's right.
Yeah.
Now, this was done in Spain. Mm-hmm. And so we can see these are what you call the control patients. Now, controls on the right, 26 controls.
Yeah.
They were given standard high-quality care. 50% of them required intensive care support. This was on admission to hospital. So 50% required intensive care support. Now, the others were given vitamin D as cholecalciferol.
The activated form.
As calcividiol, the activated form.
Yeah.
Only 1 out of 50 required intensive care support.
So all the patients admitted to hospital with COVID were given this calcifidiol, this activated form.
That's right.
And the ones that were given it,
the 50 that were given it,
way less of them. Well, one admitted to intensive care.
That's right.
As opposed to, what's the percentage?
50%.
So that's 13 admitted to.
It was 13. Yeah, 13. Yeah, that's right. This was. In Spain.
That is. Yeah, that's incredible.
Absolutely.
Yeah.
It's blindingly obvious.
Yeah.
That the vitamin D as calcividiol was having a very, very beneficial effect.
And is this expensive form? Is it difficult to produce?
No,
we're short of it?
Well, there's a vast amount of it produced. But in this country, in the UK, it all goes into animal feed, believe it or not, into cattle and sheep, cattle in particular, who are raised indoors and who are vitamin D deficient. We care more about cattle than we do about humans. It's staggering. So calcividiol is not licensed for human use in this country. It is in Spain and it is in Italy.
This is incredible.
Yeah.
So in Spain and Italy, you can buy it over the counter or your doctor can prescribe it.
Yeah, absolutely.
But you as a consultant physician wouldn't be allowed to prescribe it to me if I was ill.
Exactly.
So that's ludicrous.
Now, if the motivation was there, we saw with vaccinations how quickly they were authorised. We could have authorised calcividiol for human consumption in this country very, very quickly.
Because it's already an approved drug in other countries. It's an approved. It's not even a drug. It's just a supplement.
It's just a hormone. Yeah, it's a hormone. Absolutely. Absolutely.
Well, next time I go to Spain or Italy, or I've got a friend going to Spain or Italy, I might tell them to pop into a chemist.
That's what I did as well. Let's just move on a moment.
I'm just blown away. So the drug that had this effect, doctors can't prescribe in my country.
Correct. Now, here we are.
Yep.
This was my daughter had a friend who was going to Spain.
Yeah.
And so she told this friend, can you try and get some calcifidiol tablets, capsules? And there they are.
Yeah, and it's obviously what it is. Yeah.
That's right. Tells you what they are. And so this was obtained from Spain, and she brought them home.
And there's a dose here, 266 micrograms.
Yes, it's in milligrams there.
Yeah, 0.26.
It would be 266 micrograms.
Yeah.
But so it's readily available. Spain and Italy. I think it might be in Australia as well now. And I think possibly in Germany, I'm not sure.
I'll soon find out about Australia, right? That's interesting.
Yeah, indeed. But
I just don't get it. There's an efficacious preparation that you can buy over the counter in Spain and Italy that doctors aren't allowed to prescribe in the UK.
Yeah. And we'll see
struggling to get over that bit.
We'll see how effective it is.
Yeah.
It clearly reduces, with people with COVID-19 admission to intensive care
Yep.
from 50%
Yep.
to 1%.
Yep. Yep. Yep.
It's blindingly obvious. But
It's,
it wasn't taken on board.
Yep.
Now, the problem is, I should just go back a moment before that one.
Mm-hmm.
The problem is, we said, when this came out, this study came out, I thought, right, this is it now. We've got the randomised controlled trial that everybody was demanding.
Yep.
Here it is. But he said, oh, the trial's too small. What do we mean by too small? You just go back again, John, to the bar charts. What do you mean too small? Large trials are only necessary to demonstrate tiny benefits.
Yep.
But if you've got a major benefit like this trial's perfectly fine. There's nothing wrong with a trial of this size to demonstrate a major difference.
So if you wanted to do some research in how likely it is if you chuck people out of helicopters at 10,000 feet, how likely they survive, if you did that on 10 patients and none of them survived, that would be fairly conclusive, wouldn't it?
The parachutes are a good thing.
Yeah, absolutely, because it gives us, and this is why we have p-values in research. It would be very unlikely that result would arise by chance.
Yeah, absolutely.
So the numbers in the trial are less important than the difference, or as important between the difference between one group and the other group.
Yeah. You can take it on the spin of a coin, for example.
Yeah.
Okay, let's take the control group. You spin a coin 26 times.
Yeah.
And it comes down 13 times its heads, 13 times its tails. Well, that's fine, that's what we expected.
Yeah.
Then you take another, you take a coin and do another 50 this time, spins of the coin. And it comes down out of 50, it comes down 49 times heads and once tails. You think there's something odd going on there.
Something fishy going on here.
The chance of that happening is 50,000 to 1. Well, no one's going to accept that odds at all. That is not random.
No.
That is not a random accident. 1 in 50,000 times, forget it, that's too rare.
And if I came to you and said, Dr. Grimes, I'm ill, I want this particular treatment, and you said, well, there's one chance in 50,000 that this isn't a good option, I would take those odds.
Yeah, absolutely. Of course you would.
Yeah.
And with her, you'd say, okay, you're going to the intensive, you're admitted to hospital on account of COVID-19 pneumonia. Would you like vitamin D as calcifidiol or not? You'd jump at the chance, wouldn't you?
Dead right.
To take it. But NICE, the National Institute for Care and Health Excellence, said no, doctors should not alter their treatment of patients on the basis of this study. That was one doctor on NICE said that.
And there was no possibility. There was no possibility for compassionate prescribing.
No, none at all.
That, as a doctor, I think this is a good idea. I think I'll do it because I mean, is there a real big risk of really nasty side effects giving calcifidiol? Is this a dangerous treatment?
In this study, there were no ill-toward effects whatsoever. No side effects reported. It was only good. Nothing bad about it at all. But it's a natural hormone, of which people are mainly deficient.
If I came to you and said, look, you said there's this treatment I can give you.
Yeah.
It might not work. In fact, there's a pretty low chance it will work. But I tell you what, it's very safe. It's not going to do you any harm.
Absolutely.
I'd bite your hand off.
Of course you would.
Give it to me, doctor, please.
Yeah. But this is glaringly obvious. If this trial were to be repeated, people would die in the control group who needn't do.
Which would be completely unethical.
Yeah. Nobody, knowing these results, would go into another trial if they were informed of the results of this first one. Yeah. I wouldn't volunteer to do that at all.
No, I just want the calculator.
Yeah, I'd want the stuff that works, that's good. Yeah, absolutely.
Should we go on to the next?
Yes, let's move on. And again, we've seen that.
Yeah.
Now, that's we've got through the COVID-19 pandemic quite at this stage. And this is in New Zealand as well.
Well, we've got plenty of it, but people aren't for the vast majority of getting sick.
Yeah, indeed, that's right.
Had it myself a few weeks ago.
Yeah, all right.
Yeah.
Well, that's interesting.
Yeah.
Anyway, what this is showing in New Zealand, it exhibits it very, very well.
Yeah.
And it exhibits excess deaths. But what happens when you get a sudden epidemic, pandemic?
You get
excess deaths. There they went up 10%,
So 10%,
excess deaths. Well, people can only die once. And so when they've died, you get a compensatory reduction in deaths. It's inevitable. And there we see it in New Zealand perfectly well. We get the excess deaths in the beginning of 2020, and then we get a compensatory reduction.
Exactly what I would expect to see.
That's what you get. Yeah, indeed. So that's what we'd like to have seen in this country. But unfortunately, it doesn't always happen like that. And we were not allowed to give the treatment for COVID-19. Now, what happened in New Zealand is the strange thing is that we got through 2020, which was the pandemic of COVID-19, and suddenly we hit 2021, and the deaths go up again.
So here we've got 2021 and the deaths. So deaths in the pandemic, you would expect it. Deaths went down.
Yeah, compensatory reduction.
At-risk people have already died.
They only die once. Yeah.
So why on earth would they go up?
So it goes up again, and it's continuing and continuing.
Even higher here.
Yeah, in 2022.
And New Zealand is not the only country where this is happening.
No, absolutely. It is worldwide. And this is taken from our World in Data, which is a website anybody can look at, excess deaths. Yeah. Going up there, 30% excess deaths in March 2022. Now, I could show this for loads and loads of countries, but I don't want to bore you. This is just a good example.
We have shown this for several countries, the United States, Canada, Australia, United Kingdom.
Yes, that's right.
Quite a few Western sophisticated countries.
But the point is why this is not COVID-19. This is what I would regard as a second pandemic of excess deaths, the cause of which is not known. Let's just move on. Here we are. And it's not me that's just saying it. BBC News.
Ah, there must be excess deaths. It's on the BBC.
Yeah, absolutely.
Yeah.
A reputable organisation. This is not the social media which everyone is suspicious of.
Sorry, I was still thinking about that. Yes, yeah.
This is the excess deaths in 2022. The worst in 50 years, or among the first in 50 years. So, it's true.
You know, I like the way you put that, a second pandemic. I hadn't thought of it in those terms, but that's exactly what we're now suffering.
Absolutely.
It exactly describes it.
Yeah. Let's move on. We think New Zealand's bad. This is Japan. Wow. We see what happened in 2020. They didn't get the compensatory reduction of excess deaths.
No.
But it's now, and this is going up into November now, 20% excess deaths. A huge number.
Yeah.
This is real cause for concern. Real cause for concern.
Is this not just the after effects of the COVID pandemic?
Well, you've got to explain why. The answer is yes. A delayed illness from COVID-19, from the coronavirus, is a possibility, certainly. But what's going on? Why are people dying? What's behind these
the pathophysiological mechanisms?
Exactly, yeah. What's written on the death certificates, basically?
Because if someone's going to die, there is a reason for that.
Yeah, absolutely.
There's a cause of death.
A
disease process.
There's a disease process which is written on the death certificates.
You would hope.
Yeah.
But very startling graph from Japan.
Yeah. Now, these excess deaths in this country are mainly from heart problems. Usually cardiac arrests, actually. Rhythm-related deaths, footballers dying on the football field, people dying in gyms, but heart deaths. Now, our medical officer of health, our chief medical officer, Sir Chris Whitty, said, well, it's because people weren't taking the medications during the COVID pandemic. They weren't taking the medications. That's why they're dying.
Not a laughing matter.
Yeah. So they weren't taking the statins. Well, the most people who died had never received any medical attention whatsoever. They weren't known to have any heart disease at all. And if we look at the statin prescriptions across all practices in the United Kingdom, we can see them all here.
Well, I don't see a reduction there, do you?
No.
In fact, I see a gentle increase, if anything.
Absolutely. A gentle increase. There's no reduction.
So we're people aren't dying from statin deficiency syndrome.
No. What Chris Whitty said was misinformation. Could call it lies if you like, but it certainly wasn't true. And what he said was not true.
I'm sure he was doing his best. He just got a bit confused with the data.
There's something else though when we're on prescriptions. You can get this off the internet, as I did. Let's just move on. Now this is another one. Midazolam. Here was a treatment that NICE came up with for treating the elderly with COVID-19. Midazolam. And we can see a sudden peak in midazolam prescribing.
So
dramatic.
Did midazolam help people who are having breathing difficulties?
That was the idea. Well, the point is that midazolam suppresses respiration. It's a sedative. It's a minor anaesthetic. It should not be given to people who are seriously ill with breathing difficulties, with pneumonia. It causes them to die.
But we were giving it to people who were seriously ill with pneumonia.
Exactly, we were indeed. Yeah.
Confused now, I must say.
Yeah. It could be given as part of end-of-life care, but these people with pneumonia were not considered to be at the end of their lives. And it was the midazolam, the NICE guideline, NG NICE guideline 163 was used. Now, if you look up NG 163 now, there's virtually nothing in it. It just says alleviate symptoms. There's no mention of midazolam. It's all been removed. And clearly, this was a big, big error of NICE. So if you think NICE is trustworthy, think again. This was dangerous advice from the NICE organisation.
When I was a young staff nurse, we used to ask for medical opinions.
Yeah.
And we'd get a senior doctor to give his opinion.
Yeah.
These days, when I was working recently on A&E, medical opinions, not so much. It's more, what do the guidelines say?
Yes, indeed. Yeah.
Been a fundamental change in the philosophy of medicine there, really, over my career. Anyway.
Very much, yeah. Medical education doesn't really matter. It's just a matter of being able to read the NICE guideline.
Yeah.
And everyone's frightened of not doing.
Yeah. And everyone follows the guidelines meticulously, because if anything goes wrong, the first question would be, did you follow the guidelines?
Yeah. Instead, the different colours on this chart are the different parts of the United Kingdom.
Yeah, but there's a definite peak there in midazolam prescribing.
Yeah.
And,
absolutely.
And this peak coincides with huge numbers of deaths.
Yeah,
particularly in care homes.
Yeah.
Which was
that's right.
Tragic.
I've not got the time scale on there, unfortunately. The dates on there, but
we know roughly when that was.
We can see it, yeah.
And very often the midazolam was given with opiates.
Yeah.
With morphine.
It could well have been.
Which is a well-known respiratory depressant.
Very much.
Yeah. Right.
So let's move on.
Yep.
Excess deaths.
Yeah.
This is a new slide. Very new. And this shows, this is 2023. So it's only been available for a few weeks.
Yep.
And it shows the excess deaths.
So bang up-to-date data, 2023. Yeah. Pretty well the full year.
Yeah. But it shows that it's an international problem, with the exception of Hungary, Poland and Italy. So why? I've no idea. Can't explain it all, but it's a big problem in many countries. I'm going to see the UK, 9.4% excess deaths during 2023.
And the figure for 2022 was actually about the same.
Yes, that's right. Yeah.
And that equates to, in the UK, nearly 50,000 excess deaths.
Yeah. Yes.
And if we add
1,000 a week.
If we add that to 2022,
yeah.
And these are not COVID deaths primarily, we're talking well over 100,000.
That's right, yeah. There are some COVID deaths in that, but not many. Not many at all.
I mean,
In
that
fact, the
is
government
really-
has stopped reporting COVID deaths or even COVID incidents these days.
Yeah.
It's come to an end.
Yeah.
That shows how big a problem it is in many countries.
So Canada, huge excess deaths.
Yeah.
New Zealand, Australia,
Yeah,
Chile, Israel, Iceland. The United States is pretty bad as well.
yeah. Well, it's 155,000 people in the United States
Yeah.
in the year.
Yeah. Yeah.
Japan isn't on there, you'll notice. I don't know why not, but
Yeah.
they couldn't put it. Not every country could
No,
be put
it's
on
just
that
a selection
table.
of countries,
Yes.
yeah. But
Yeah.
second pandemic is a fair way to
Yeah,
describe this.
yeah, indeed.
Yeah.
This is very interesting information from Germany. Yearly excess mortality of these 3 years, 2020, 2021, 2022. And we can see in 2020 there were not many excess deaths.
But you would expect a lot more in the pandemic year.
You would. Now, the interesting thing is if we look at the 90 to 120 age group towards the end,
Yeah.
there were very few excess deaths, which is very surprising. What would have happened is that the ones who were going to die in the first half of 2020 did do, and the ones who were going to die in the second half of 2020 also did do. So, averaged out, there were low deaths in the second half of 2020. People didn't die because they died in the first half instead. The interesting thing is also that the number of children dying in 2020 was right down. Minus 6% childhood deaths. Well, they weren't at school. They weren't playing out. They weren't getting run over. There were no cars on the roads. So it was safe for the children in terms of their physical state. Not so safe in regard to their mental state, I think it's true to say. So we can see 2021, deaths were higher than in 2020. Children's deaths were not quite as low. Children started to go back to school. And in 2022, we can see the deaths, excess deaths are far higher. And it wasn't just in the elderly, it was in the ones where the arrow is. 15,
Young people.
yeah, young adults. From
So
15,
great. So we've got from naught, certainly from 15-year-olds,
yeah.
30-year-olds, people in their 40s.
Yes, it's right. The age groups 15 to 40 have got the highest deaths there. The people in the age group 50 to 59 is low for reasons which I couldn't possibly understand. But the elderly also had excess deaths. So you expect that.
In Germany, as in other countries, higher deaths in young people in 2021
That's the
and
point.
2022.
So rather than just looking at the total number of excess deaths, we're now looking at the numbers in relationship to the age group of the population. So it adds a lot more. This is very interesting. Let's have a look. Another slide.
It's almost as if there's some factor which might have caused these deaths, which we should be looking
Well, there is indeed. We've not yet got on here the reason, the actual what's written on the death certificates, but never mind. Now, the other thing is, it's not just deaths either. It's illness. My local newspaper, excellent newspaper, the Lancashire Telegraph, headline was the busiest ever day for the A&E ward, and that is on
15th of June 2023.
Yeah, that was June. Now you expect
This is the middle of summertime
middle of summer
in 2023.
Yeah,
It's not what I would expect at all.
no, and June, excuse me, and June 2023 was a very, very nice month. May and June were excellent.
I remember it.
It started raining in July, and it only stopped after Christmas.
It did, yeah.
It only stopped last week, didn't it, really? But why we should have the busiest ever day for the A&E ward in June and in 2023 is not obvious.
Because in hospitals, normally we get an influx of CO, chronic airway disease, in winter.
That's right.
And falls, and it's normally winter that's busy in A&E.
It is indeed. And this was 2023, not 2022, the year of the COVID-19. This was...
Well, 2020, 21,
Yeah, that's right. This was later.
Yeah.
2023. Now, why it was busier now ever than during the COVID pandemic should be a question that should be asked and answered.
It's a fair question.
It's not just deaths, but it's illness as well that's going up in this second pandemic.
More people ill and more people dying.
That's right, yes, indeed. Absolutely. Yeah, that's clear. Now then, we can't escape the thought, the supposition, that vaccinations might be responsible.
Or partly responsible.
Yeah,
It's a factor
absolutely.
it's something that's changed in the population.
Yeah.
So it should be considered as a possible cause.
If we've got something that's occurred since 2020, it's either the after effects of the virus or it's the effects of the vaccination. We can't ignore it. You know, it's like the post office ignoring that the computer, the Horizon computer, was the cause of all the accounting errors. You know, it was denied and denied and denied, but this week it's not being denied. It's being accepted. But people will deny that the vaccine caused the damage. We don't want something that we've done to be causing ill effect on such a huge scale. It doesn't bear thinking about. We've given millions and millions of doses of vaccines out and that they've caused problems. But here we are. AstraZeneca's facing a legal challenge. The AstraZeneca vaccine was actually withdrawn from use in this country in, I think, early 2023.
Even before that, I think.
Certainly before that in Scandinavian countries. But a legal challenge. And what they're saying is that the vaccine was defective. This was just in November. There are 2 test cases going through, but there are a lot more behind it. So it is on the surface anyway. It's reaching the surface of public knowledge that the vaccines are being challenged in terms of their effect and damage that they might be producing. Because the legal challenge is over people who are damaged by the vaccinations. There's no question about that some were. There was a BBC announcer called Lisa Shaw who died tragically about a few days after having the AstraZeneca vaccination. And, you know, that was a long time ago. That was in 2021.
I think it was admitted that was the cause in that particular case. But so many other cases, it simply hasn't been addressed.
No, indeed. Yeah. So it is coming to the surface now. The vaccinations might be causing trouble after all.
I mean, in terms of medical science, I mean, should we consider all factors or should some factors be rejected a priori?
We should consider everything, shouldn't we? Really, you know, quite honestly, we can't. I mean, you know, if it stops me getting sick, I'll consider the phases of the moon. Yeah,
I'll consider anything.
Yeah, indeed, that's right. That's right.
I don't like pain and sickness.
Yeah.
And I certainly don't like death.
That's right. Yeah. But is there any rational view of this? Is there a way in which the COVID vaccines might have caused this sudden increase in illness and deaths? We could say they're toxic, but there's another way of looking at it. Let's just move on. This shows, excuse me, this shows once again the activation process of vitamin D. We've got, as I say, coming from food or skin, vitamin D, activated in the liver, and then entering the blood in reserve. That is the reservoir, the reserve of vitamin D is held in the blood as calcifidiol, 25-OHD calcifidiol.
And this is the one
it's held in the blood.
This is the one we measure when
That's what's measured, yes, indeed. And when it's required, it's taken up from the blood into the cells. And here we have the immunity cells. It's the interesting ones.
So this could be something like, I don't know, a lymphocyte or a...
Yeah, that's right.
Monocyte
yeah,
or a
absolutely.
macrophage or
In particular, it's the T cells, the important ones.
T lymphocytes.
Yeah, T lymphocytes. So we can see that the 125 calcitriol or calcividiol, calcividiol goes up. Another OH group is added. It's now 125 OHD calcitriol.
Yeah, this was the slow reaction.
Yeah,
this was the
quick one. Yeah, quick, instantaneous almost.
Yeah,
and it combines with VDR, the vitamin D receptor, and also RXR, which is related to vitamin A, and it activates. This combination activates the genes, the nucleus genes, the genes in the nucleus, to cause the cell to produce defensive proteins or go into a defensive mode. And these defensive proteins get into the tissue fluid. And that's how bacteria and viruses are effectively killed and controlled and killed. So this is what's going on. The stimulus of immunity cells using up calcitriol. Now, the point is that calcitriol, a molecule of it, can only be used once. And after it's been used to activate the cells with VDR, it's deactivated. It becomes 24-25 OHD, which is inactive. Now, the cells can produce any number of VDR molecules, big and complex as they are, produce any number, but the cells cannot produce vitamin D in any form.
So these VDRs are specific proteins that the cell produces just to receive vitamin D. They're vitamin D receptors.
Receptors, that's right.
And it's the combination of the vitamin D and the vitamin D receptor that activates the genes. The genes,
yes.
And the activated genes produce these defensive proteins.
And this can be in a lot of different cells, because I think it's about 2,000 of our cells, 10% of our cells, contain genes which are responsive to vitamin D VDR.
Wow.
VDR is a big, complicated molecule. 125 OHD calcitriol is a tiny molecule, really, but it requires that. It's like having a big, expensive car. It doesn't go if you've not got a key. If you lose your key, you might as well not have a car. You need the key, and the vitamin D is the key to unlocking VDR, to allowing nucleus activation, allowing the immunity cells to do the job.
So we've got all these genes sitting there just rearing at the bit to produce defensive proteins.
Yeah.
But they can't do that without the vitamin D to switch it on.
Exactly. But the point is to emphasise that the vitamin D molecule can only be used once.
I didn't realise that. It gets used up in this process.
It is consumed.
It's a bit like money.
Yeah, that's right. Yes, indeed. So basically,
you only spend it once.
You only spend it once. But yeah, that's a very good analogy. You've got to have an income. You've got to have an income stream, haven't you?
The analogy goes on.
Yeah. So the income stream for this process is food and skin producing vitamin D. Yeah. And if food and skin have got to provide enough vitamin D to replace the calcitriol, which is only used once and then destroyed. Yeah. So it's one way it's like a conveyor belt. You've got the vitamin D coming at one end and it's going out.
So we need a constant supply.
We do indeed. Now,
which is why it's called a vitamin, of course. It's vital.
Yeah. Yeah, it is indeed. Yeah. We can't produce it ourselves, but we can produce any number of VDR cells. But once we run out of vitamin D,
strange we can produce the clever things, but not the.
Yeah, it's fascinating. It's incomprehensible, really. Yeah, an accident of evolution.
Yeah, amazing.
We can only produce a 7-DHC, the precursor of vitamin D, and then we rely on the sun after that. It is. An accident of evolution is fascinating.
I mean, biochemists would probably give us some really clever reasons for why it's necessary, but beyond my ability to understand.
It's something to do with evolution, really, and it's very difficult to understand. It's been happening, as I say, vitamin D has been produced for 1.5 billion years, but I suspect that VDR only came into evolution about 500 million years ago. The time of the Cambrian explosion of life, I suspect. I think it's been around for that length of time.
That's when life became complicated.
Yeah, that's right. And required immune cells.
Yes.
But this is the important thing, though. Once vitamin D supplies are exhausted,
Yeah.
VDR stops working.
Yeah.
And the immunity cells stop working, basically.
Your expensive car has no key, therefore it's completely useless.
Yeah, that's right. And the immunity cells do not work without vitamin D coming in from food or skin.
Yeah.
And we know very well that the vast majority of people are deficient in vitamin D.
You've clearly
They don't have,
Clearly.
they don't have the reserve.
Yeah.
So the supplies of vitamin D are easily exhausted by infection. Because infection causes activation of the immunity cells.
Just uses it up.
Use it up.
Yeah.
Let's look at another slide.
Yeah.
And here we have an example. So we have two people coming into the system here.
So person one.
Person one in green and the person two in blue.
Person two in blue.
The person in green has got a good level of vitamin D in the blood. The blue person has not very much.
Yeah.
So they hit COVID-19 infection.
Here.
Yeah.
Both at the same time.
Yeah, both at the same time they get COVID-19.
Yeah.
And the vitamin D level in the blood is knocked down. It's consumed. I've knocked it down there by...
Literally used it up.
Use it up, yeah.
But that's
Goes down.
okay because they started with a fairly high level.
Yeah,
Or it's more okay.
yeah, indeed.
Yeah.
Now, if it was just a matter of COVID-19, they wouldn't be too bad.
Yeah. So this person here with the low level,
Yeah,
they're still above the sort of
the critical
level.
Yeah,
Yeah.
that's
So
right.
it's down a bit.
Yeah.
Yeah.
They'd have continued with a level of 15,
Yeah.
and these are in nanograms per mil, I'm afraid, not nanomoles. Don't forget that 20 nanograms is 50 nanomoles.
Yeah. So 15
Yeah,
nanograms per mil
yeah.
would be 37 and a half. 37 and a half nanomoles per litre.
Yeah.
Yeah.
Now, that's okay. We'd have got by that.
Yeah.
But suddenly,
We're just getting by here.
we get vaccinations. Now, the thing is, of course, the people who had COVID-19 were given vaccinations. Could never quite understand that because with Hong Kong flu, there are no vaccinations available. But once they got the disease and recovered, then they got immunity. So they didn't get it again.
Natural, active,
Natural immunity.
acquired immunity.
Natural immunity, yeah, indeed. But here we get a vaccination occurring. Now, a vaccination mimics an infection. It does the same thing. The purpose of it is to mimic the infection to produce an immune response, which means mobilizing the immunity cells. So here we are, vaccination one, and we get a repeat performance, basically. And we're going to get again, the immunity cells are going to be called into action.
So the immune cells use up the vitamin D to produce the immune response.
Yeah, it's inevitable. I must admit, it has not been demonstrated. The research has not been done behind this. This is a theoretical slide, but it's highly justified. Had I been working, I might have been able to undertake this research. On the other hand, I might have been forbidden for doing so.
But we know that an infection uses up vitamin D.
Yeah,
And an infection involves generating an immune response.
Yeah.
So a vaccine generating an immune response.
Yeah.
If it's using, for example, in the immune response, you'd need your T stimulator cells
Yeah.
to tell the plasma the cells to produce the antibodies, wouldn't
yes, yes.
it? The B cells.
Yes.
The B. So you need the T cells, you need the B cells.
Yeah,
you
the
need
B cells are the
production.
antibodies, the T cells are tissue immunity, yeah.
Yeah, that's obviously involving stimulation of immune
Yeah,
cells.
yeah.
It seems obvious it's going to be using vitamin D.
Yeah, it's got to. If the vaccination's going to work, they've got to activate the immune system.
Maybe a philanthropist would come forward with the funding
Yeah.
for this research.
Well, yeah, but the Gates Wellcome Foundation had a research accelerator,
Good idea.
which forbade use of research about vitamin D. It was forbidden. It's in the documents, which I have. Research into vitamin D, concerning vitamin D, will not be funded by the Research Wellcome Foundation Accelerator.
But I thought in science the idea was to do the research first.
Yeah.
And then look at the data.
I know. Crazy. Crazy.
I must fundamentally must understand the nature of science.
Anyway, in respect of this, one vaccination would have knocked it down, but one vaccination wasn't enough. We had to have multiple vaccinations. These are 2 vaccinations. And this would have sent the blue person into a dangerous level.
This is the danger zone, isn't it?
It is, yeah. Seriously vitamin D deficient. Seriously immune deficient at that stage. Yeah. Now let's look at another one. Unfortunately, I've changed the numbers, the colours round. Doesn't matter. Okay, right. Sorry about the change of colour.
This is the good bit at the top.
Yeah. The good guy, the lucky guy, took notice from the first time. Yeah. He said, I'm going to take vitamin D supplement. So he takes vitamin D supplement, and people have often had 4 or 5 vaccinations, you know. And people say to him, I've had 4 vaccinations, and I've had COVID twice since then. How very strange. So here we have the vaccinations, knocking down the blood level of vitamin D.
So it knocks it down here, down we go.
But if you're taking vitamin D supplement continuously,
up we go.
You go back up again, and down again, and back up again. And you finish up after your series of vaccinations with a good blood level of vitamin D. Yeah. But the poor guy with the green guy this time, who starts off with a low level of vitamin D, it doesn't take long for him to get down into the lowest level. And clearly, I didn't continue the graph then because the chance of death is very high. Below that black dotted line, there's serious immune deficiency because of lack of vitamin D. Yeah. And we've seen that in COVID in Israel, how dangerous it was to have a lower level of vitamin D. So what are we going to do about this? What can we make of this? It's quite clear what could have been done. The continuous vitamin D supplement. The knowledge has been accumulating right through the era of the pandemic, through 2020. A lot of information added, like we've seen from Israel, but no notice was taken of it. So we're left now with our second pandemic of excess deaths and excess illness. Hospitals busier than ever. Hospital corridors looking like a war zone.
And they really are. I mean, conditions, talking to colleagues at the moment on A&E, it's just unsafe.
Absolutely. It's a complete nightmare, I'm told.
Yeah. No, it is. It definitely is. Yeah.
Good. It's
terrible.
Let's see what else we've got. Now, this is interesting. Now, T cells. We've got a model of AIDS in recent decades. Yeah. And AIDS, acquired immunodeficiency syndrome. And in that condition, people had a series of strange infections, and rare cancers became common. People were dying mainly from cancer and infections. And one of the main infections people with AIDS acquired was tuberculosis. So hang on, now we've got government report, government UK, tuberculosis cases continue to rise in England in 2023. Increased by 7% in the first half of 2023. That's bad news. This, more than anything, tells us that at the moment we have, within our society, serious immune deficiency.
Because of the resurgence of tuberculosis.
Yeah, that's the index. It's just like with AIDS. If you saw tuberculosis, it was vitamin D deficiency or AIDS, and that was one of the problems with the South Asian immigrants into this country. They didn't have tuberculosis when they came to this country, but after about 6 years in this country, they started to develop tuberculosis. It was activating because they were seriously deficient of vitamin D.
So they would have had dormant tuberculosis.
Yeah, absolutely.
Previous infection.
Yep, Yep, that's right. Dormant and it activated when the vitamin D was exhausted. And it's the same here, I'm sure. The one we have now is a serious immune deficiency syndrome, like AIDS, well, you could say, well, it might have been due to the coronavirus, like AIDS is due to the HIV, the HI virus. And it could be due to the coronavirus. Well, it might be. I do realise now that we're in a phase of serious immune deficiency, which is why people are still developing COVID after they've had the vaccinations. But I think that these series of vaccinations are using up vitamin D. They're depleting us of vitamin D. They're causing vitamin D deficiency. It could very easily be tested, and it could be even more easily dealt with and treated. If what I say is true, it is reversible. If, on the other hand, what some people say, that vaccines are causing a toxic damage to the body, then I don't know the answer to it, I'm afraid. But there's hope for us if it is due to vitamin D depletion, due to the repeated vaccinations.
But even if this is only one factor, and I think it's a big factor,
yeah,
let's get rid of this one factor and then we're all better off.
Yeah, absolutely.
And we've eliminated that variable so the research becomes more transparent.
That's right. If there's a demand from public health for us to have more vaccinations, well, I'm not one to say don't do it, but I am one to say don't do it until you've got people with good blood levels of vitamin D. Look at the population, check the blood levels of vitamin D, see how bad the problem is, and correct it.
And if we did that, and the vitamin D did nothing to help infections,
yeah,
we haven't done any harm.
No, we haven't at all. But it'd be interesting to see, though, what will happen to these excess illnesses and excess deaths that we're experiencing at the moment. What effect it would have on all these people coming into the A&E departments more than ever in the past 50 years. You know, there's a way of dealing with it, John.
Yeah.
There's a simple way of dealing with it, which will be cheap, hopefully very effective, and not in the least bit dangerous. Mm-hmm. We need to do something.
What's not to like? It's safe and effective. Safe and effective.
Safe and effective.
Safe and effective.
Well, we certainly know it's safe. There's a very, very good case.
Colour into it, that's safe and effective.
Yeah,
it kind of goes
I've heard
together,
that before.
It kind of goes together, doesn't it?
Yeah, it does indeed.
Safe and effective.
Safe and effective, yeah, indeed. That's right. So,
but this is safe and effective.
Well, we know the problems. We've seen the problems of having low blood levels of vitamin D. We've seen the problems of a second pandemic, which seems to be related to deficiency of immunity, immune deficiency. We've seen the parallels with AIDS, and we know very well we can correct vitamin D deficiency very, very easily.
Let's go and do it.
I think so.
Yeah, great. Dr. Grimes, thank you so much. Learned lots.
Okay, John.
Incredible. What I find is my mind's just sort of spinning now. I've got maybe after a cup of tea I'll have a few more questions, but some really stunning information there, and just the potential to, I believe, revolutionise the health of countries. Yeah, because we are in a pandemic of immune deficiency.
We are, absolutely, very much so. Serious problem.
Doctor, thank you so much.
Pleasure, John.
Appreciate your time.
Thank you for inviting me.
Thank you, John.
Much.